I'd like to call the afternoon session into being. And I'm going to start out just asking Dr. Foster to provide us with the website so we can enter this in the minutes in terms of the American Pharmacy Association website that details state-by-state laws in terms of age of vaccine recipients and the vaccines covered.
And Stephen, before I do that, just for the minutes, so we're official, we have a quorum for the afternoon. We have 12 voting members here. One will be on the telephone, and we have 5 ex officios. We need 13, and we have more than that. Thank you.
Thank you. The American Pharmacists Association website is www.pharmacist.com. And if you can either go directly by selecting the immunization center, or you can type in, if you want to carry that on, pharmacist.com/immunization-center to get you directly to it. In the middle of that section, it's got a top resources area, and the slides that you saw on this presentation with the pharmacists and the states are actually on that website.
Thank you very much. With that, I think we will move on to the session on influenza with Dr. Keitel doing the introduction.
Just one, I actually have, this is Lisa Grohskopf, I have 2 brief things to mention. One is logistic. For some of you, you may find that the presentation printouts for session, the 3rd talk, Dr. Dan Jernigan's, is not in sequence. For some of you it will be, but for some of the handouts it's out of sequence, and you should find it as the last 4 pages of your packet. So that's a logistic thing. The second thing I wanted to say personally for myself and also on behalf of the work group, thank you to Wendy. It's been really an exciting couple of years. I've learned an awful lot, and thank you very, very, very much.
Thank you, Lisa. Well, good afternoon, everyone. Before I start the introduction to the flu work group presentation, I just want to make a few comments about the experience that I've had here over the past 4 years, and I follow along with everyone who's gone before me to say that this is just an incredible experience, and I'd like to thank the ACIP leadership, including Larry and Jain and Carol Baker and John, and the people around the table in the inner circle today, as well as several who have left, in particular my ACIP mentor. You know, we all get paired with someone, Cody Meissner. And then all of our liaison and ex officio members, the people who sit in the audience, and not least the people from the public who come to share their stories and remind us about the face of these diseases. I want to thank you all for an incredible experience, mine being basically vaccine development, and this having given me a totally different perspective from the public health standpoint. So with that, I'll begin the introduction to the flu work group. And I joined the work group in 2009 during the pandemic, when the group was under the leadership of Dr. Kathy Newsel, and her CDC, once called lead, was Tony Fiore, and the little cartoon you see there is in memory of Tony. And at that time, when Kathy rotated off of the ACIP, she gave us a very nice perspective on the introduction and use of influenza vaccines in the United States, starting with their licensure and up until 2010, when we voted as a group to recommend universal immunization of everyone 6 months or older who is a candidate to receive influenza vaccine. And with such a sweeping recommendation, there clearly came a great responsibility, even greater than in the past, to ensure a number of different things, that each year we would use the vaccines properly and issue recommendations to the providers on how to use the vaccines, as well as antivirals, to ascertain vaccine effectiveness and to ensure vaccine supply and, importantly, the safety of the vaccines. So you see there that the flu work group really has a very broad scope of activities, which continues on an ongoing basis. Also, during this time, ACIP endorsed the grade approach to recommendations, and this process has been launched for influenza vaccines, but I don't think it would take a great imagination on the part of anyone in the room to see that this process is going to be very complex for influenza based on the different numbers of age groups, risk groups, as well as vaccines available for prevention of influenza. And I am very sure that with Ruth Karen at the helm as we really pursue this quite vigorously, that we will focus our recommendations so that they have more specificity with regard to use of particular vaccines in particular populations to maximize the effectiveness of their use. We've also entertained a lot of presentations on certain safety issues, including febrile seizures, heard surveillance, and have been briefed on emerging viruses, including the H3N2 variant viruses and H7N9. And quite recently, you can see 5 new vaccines have been introduced into the armamentarium, which greatly expands our ability to respond both seasonally as well as in the setting of a pandemic to influenza's, the problems influenza poses. And so this picture here can be interpreted in different ways. I think it was used as a metaphor for herding cats in another context, but I rather see it as the cowboy's not really hurting them, it's trying to rein in those cats. And that's basically what we're trying to do, is to control the evolving and diverse problems that influenza and vaccination against influenza poses. So first of all, the influenza work group is awesome. It's quite large, and the members are really dedicated. They attend usually a call every other week. It's not every single time, but generally every other week, to address these diverse issues. And I'd like to thank the ACIP members who have served on that, pass the baton to Ruth today, to thank the one-time lead and now the designated federal officer, Tony Fiore, then Tim Uwicki for a brief period, and most importantly, Lisa Grohskopf, who has just done a phenomenal job keeping the balls up in the air and not letting anything fall behind. Thanks also to the ex officio members and liaison representatives who have dedicated their time and their knowledge and wisdom to this process. Since last presentation in February, we have successfully published the MMWR policy note based on what ACIP approved with regard to immunization for the 2013-2014 influenza season. The draft 2013-14 flu statement is out, and there will be a few votes today that focus on a small piece of this related to egg allergy. And during the past several months, we've been discussing the quadrivalent vaccines, delving more deeply into the issue of the vaccine effectiveness for the 2012-13 season, which generated a lot of discussion, I believe. And we'll have an update on influenza. We've heard about influenza vaccine safety issues and issues related to vaccination of patients with egg allergy. And so today we'll have a surveillance update followed by an update on influenza A, H7N9. We'll hear a more detailed analysis of vaccine effectiveness for the past season, and about potential public health impact of using quadrivalent influenza vaccines. Then we'll hear a little bit about FluLaval and the 2013-14 recommendations, and we've saved the votes, which again are small votes, for last. And last but not least, I'd like to thank the huge number of CDC individuals who've contributed to the education of the work group and to the education of everybody in this room, and all of the people who have made it possible for all of the ACIP members to attend this meeting with such ease and to make things work so smoothly. Thank you all very much.
Good afternoon, everyone. I'm just going to present a short update today from the surveillance data. First, our virologic surveillance. You can see from these data, we had about 311,000 specimens tested this year, and of those, 73,000 were positive. And this gave us an overall percent positive of 23%. That percent positive peaked the last week of the year, week 52, which is December 31st, and that high peak was 38%. Overall, we had a predominance of influenza A, and specifically H3N2, and we had about 71% overall influenza A and 29% influenza B. Now, even though we had a predominance of influenza A, specifically H3N2, we had influenza B predominate from about week 7, which is about right here on the graph. Week 7, or about the 23rd of February on through the rest of the season, and that predominance still holds on. Right now, we have an overall percent positive of about 3 to 4%. Antigenic characterization is as follows. The 2009 H1N1, which was an overall very small percentage of the total viruses that we saw this year, about 4%. 252 viruses were characterized. 98.8% of those were California 7, the H1N1 component of the 2012-13 Northern Hemisphere vaccine. Of the H3N2 viruses, 1,324 were characterized, and 1,319, or 99.6%, were characterized as A Victoria 361. The H3N2 component of the 2012-13 Northern Hemisphere vaccine. Of those influenza B viruses, the Yamagata lineage was 66.3% of those viruses. 879 were characterized, with 581 from that lineage, and characterized as B Wisconsin 2010, the influenza B component of the 2012-13 Northern Hemisphere vaccine. The remainder, or 33.7%, were the Victoria lineage, and 879 of those viruses were characterized. 295 were characterized as Victoria lineage. Antiviral resistance, you can see by looking at this slide that we had very little antiviral resistance. No influenza B viruses were resistant, and of the H3N2s, 2 viruses were resistant to oseltamivir. 1 virus was resistant to both oseltamivir and zanamivir, and 1 was just resistant to oseltamivir of the H3N2s. And of the H1N1s, 2 viruses were resistant to oseltamivir. ILI syndromic surveillance. This is the ILI net coverage, and you can see that we have a lot of ILI net providers where people live in the US, and the underlay of this map is population density. And we don't have a lot of ILI net providers where no one lives. You can imagine there aren't a lot of ILI net or doctors where people don't live. These are the percentage of visits for influenza-like illness from this network for this year and other selected years. The red line is this year with the triangles on it. You can see we peaked at a very high rate this year at 6.1%. The other two lines that you see that are also very high are the pandemic year, and that was 7.7%, and 2003-04 at 7.6%. These are two of the highest years recorded in this system since 1997, and you can see we didn't do so shabby this year either. It was a very bad flu season. We characterize it as moderately severe at 6.1%. We're down here right now at a little less than 1% as of June 8th, 0.9%. And hospitalization surveillance. We had a particularly severe year for the elderly. In this figure, you can see on the x-axis is the MMWR week, with this week being January 1, week 52 is December 31st, and these are the rates per 100,000. There's a 2012 graph inset here for your reference point. This which you can hardly see, I'm just going to give you a reference point here. This y-axis is half of this year. It goes up to 95. This goes up to 200. You can see here the elderly rate is about 40 last year. This year it's 191. This rate for the elderly this year is 2.5 times the rate ever recorded in the history of the system. We've been doing surveillance for adults in the system since 2005. So not for such a long time, but for about 8 or 9 years. The overall rate for hospitalization this year is 44 per 100,000. You can see for the elderly it's 191 per 100,000. The next highest rate is for the 0 to 4-year-old age group at 66. And then the other rates for the other age groups are much lower than that. So this year we had a lot of hospitalizations, especially for those over 65. And compared to last year, this year was a very severe year. The last highest rate year we had in this system was 2007-08, other than the pandemic year. Mortality surveillance. These are the number of influenza-associated pediatric deaths by week of death from 2009-10 to 2013. You can see that we had a particularly severe year during the pandemic with 348 total deaths. Then 2010-11 was a fairly moderately severe flu season as well. Then last year we had hardly any pediatric deaths, just 34, and that was characteristic of a very mild flu season, which we had last year. And this year we had 152. This is the highest rate, other than the pandemic, that we've had since surveillance began. We began the system in 2003-04 after a particularly severe season in which H3N2 and influenza B circulated. That year we had 153 pediatric deaths. This year so far, as reported last week, 152. These are the pneumonia and influenza mortality deaths or percentages for 122 cities. You can see that we had overall a particularly high proportion of deaths for pneumonia and influenza this year. We had 9.9% of all deaths be for pneumonia and influenza. This looks pretty bad when you just look back to 2008. But for 2003-04 and in the 1990s, 90-91, and in the early 90s, we had a much higher proportion than this particular year. But all in all, this was a particularly severe year. It was a little bit higher than 2007-08, but as I said, for 2003-04, we had a much more severe year for P&I mortality. And this is weekly influenza activity reported for this past week. For week 20, which is May 18th, and you can see that there's very little flu circulating. As far as the summary is is concerned, influenza activity in the U.S. During the 2012-13 season began approximately 4 weeks earlier than usual and occurred at moderately high levels. Activity peaked in late December, week 52, December 31st, and H3N2 viruses predominated overall and until late February. After late February, B viruses predominated, and they've continued to predominate through the rest of the season. There were high rates of influenza hospitalization, especially in the elderly, and the peak percentage of outpatient visits was 6.1% and was one of the highest reported since the system began its current format in 1997. The number of pediatric deaths was the highest reported since surveillance began, excluding the pandemic year. And I'd like to acknowledge all the people in our branch and also the people in the surveillance group. Thank you.
Okay, we'll move along to the H7 and 9, and then have time for some questions on the two epi talks at that time.
Thank you very much. I want to talk very briefly about the investigations and the epidemiology of the influenza H7N9 that occurred over the last few months. It really is a manifestation of a post-SARS era, a post-2009 H1 era, which really shows the response, how it differs with the speed of technology and with the benefits of transparency. On March 31st, 2013, the China Health and Family Planning Commission notified WHO of 3 cases of human infection with influenza A H7N9. This points down to a reference there, the MMWR, which actually has a lot of this information in it if people want to follow up on that later. The 3 first cases were from 2 places, from the Shanghai municipality and from Anhui province. All 3 cases presented with respiratory tract infection with progression to severe pneumonia and breathing difficulties. There were 2 deaths, and 1 was in critical condition at the time. I think this is in very bright distinction to the H7 cases that have been reported previously, which were mostly very mild. Those 2 cases, just to place them on a map, you can see the Shanghai here and the cases in the 1 case in Anhui province. I think it's important to point out that this area is about 575 million people, about 45% of the population of China, and about 8% of the population of the world. So I think it points out that what happens here can have a significant impact in terms of travel and where people can go. Also want to point out, I think, the proximity to Korea, to Vietnam, and others that are very close by. In terms of the cases, there were overall so far as of June 20th, 132 laboratory confirmed cases. 127 or 96% were hospitalized, about 60% recovered, about 30% died, so a case fatality ratio of 30%, and 77% based on 1 large study of individuals had exposure to live animals, mostly chickens and ducks. The point about lab confirmed, I think, is important too, because in terms of speed of technology, at least with CDC and with the China CDC, the development of diagnostic kits was extremely rapid. Here in the U.S., we were able to get them FDA cleared under an emergency use authorization and get them to all 50 states and to the Department of Defense and other places around the globe. Cases have been diagnosed in 8 provinces in China, 2 municipalities, and in Taiwan. There have been 5 lab-confirmed clusters. There is human-to-human transmission is possible. However, these clusters are mixed in with a lot of exposures to animals as well, so it's difficult to know if there is actually human-to-human transmission alone. There's 1 lab-confirmed asymptomatic infection in a child in Beijing. There have been over 2,000 contacts followed so far. Only 2 were laboratory confirmed positive by PCR to be cases. In the U.S., the U.S. Virologic surveillance and influenza surveillance was ramped up for people coming back from China and from that area, and 67 people were found to be suspect cases, but all of them turned out to be negative by PCR testing. This is a map that shows where the cases have been occurring. You can see Shanghai there, sort of in the middle on the coast. Really just a general explanation is it seems to have started there and moved out. That's what it looks like. At this point, you can see the contiguous provinces that have been affected and the amount of individuals that have died or recovered. Again, most of this occurring early in Shanghai, where a lot of the strong population amount is. This is an epidemic curve of the H7N9 virus cases. I think the point here is it looks like a regular epi curve. It goes up and then it comes down, which is a good thing. You can see the colors of the different provinces, municipalities, or areas around China. And you can see that the colors seem to go in waves, basically representing that the virus appeared in places, had cases occurring, and then seemed to not have any more cases occurring in that area. Exactly the reasons for this are not quite clear, but I'll get to that in a second. In terms of the demographic information of confirmed cases so far, if we were to try and make a generalization overall, we would say that it's predominantly severe disease in older men with underlying conditions, which is a different kind of epidemiologic assessment than from other novel influenza viruses. In terms of the age, you can see in the red squares in the total column, mostly older individuals. In terms of the gender, mostly men. In terms of severe infection, 86% having, quote, severe infection, and 95% having underlying conditions. I think, again, that's important to point out that prior human illness due to H7 has been mild, generally with conjunctivitis when it causes disease in humans, and only one death reported previously. So there's something different about this virus, and that's one of the reasons why many people are very concerned about it. In terms of the age and gender distribution, again, you can see here in the different colors, the females and males, the 62 years being the median for men and 59 years for women. If you look at the age distribution of H5N1 compared to avian influenza H7N9, for those cases that have occurred in China, you see this very different epidemiologic phenomenon. And that is much younger, 26 years is the median for H5, and 61 years for those that are from H7. So again, something very different happening here. It raises the question of why older men with underlying conditions. Exactly the reasons for that are not clear, but I think there have been different descriptions that have been provided by different folks. Some of our colleagues at FAO and OIE indicated that older men tend to do the buying in live bird markets in Shanghai, which may be different in other places. In addition, younger individuals tend to buy processed food and not buy buy food from live markets. And older individuals, especially older men, tend to smoke a lot more than older women and have underlying conditions that may be associated with that. In terms of the laboratory investigation, there have been, actually this slide actually should have been updated, but there have been 43 human viruses that have complete or partial genome sequenced, representing 35 cases. All of the genes that have been sequenced so far are of avian origin, and I'll get to a diagram in a second on that. In terms of the genetic changes that have been identified from genetic sequencing, there are three things that have been pointed out that are of concern. They have identified adaptations that lead to enhanced virus binding to mammalian respiratory cells, enhanced replication in mammalian respiratory cells, and increased the severity of infection. So these changes, these mutations that have been identified have been associated in the past with those features in animal models. In terms of antiviral susceptibility, overall the virus is susceptible to oseltamivir and zanamivir. One virus shows resistance to oseltamivir and zanamivir. However, the clinical relevance of that virus is not known at this time. This is a diagram that does show the origin of the different genetic sequences, just to show that all of the 8 sequences are from, all of the 8 genes are from poultry and from wild birds. You can see the HA gene, the NA gene, and all of the internal genes have been combined, and likely some intermediary animal host that allowed for some of the possible animal mutations to the mammalian adaptations to occur. In terms of serologic studies, studies using the hemagglutination inhibition and microneutralization assays with serum from individuals vaccinated with the 2012-13 seasonal trivalent inactivated vaccine showed no existing cross-reactive antibodies to H7N9 either before or after vaccination in young children, adults, and older adults. So basically this demonstrated that there was not any cross-reactive antibody. Preliminary results of the National Health and Nutrition Examination Survey, SERA, collected from the general U.S. population in 2010 suggest there are very little to no pre-existing cross-reactive antibodies against H7 in all age groups tested. So across a wide age spectrum, there does not appear to be any existing immunity in the population. Sera from individuals that had received 2 doses of a Eurasian lineage H7N7 live attenuated influenza vaccine, and then 1 dose of a Eurasian H7N7 inactivated vaccine, which is a prime boost phenomena here, it showed good reactivity for the H7N9 virus, and I believe that's not published information yet. Candidate H7N9 vaccine viruses have been developed and have been provided to vaccine manufacturers. A clinical trial of inactivated, non-adjuvanted vaccine is planned. The dates for that I don't have. And decisions for stockpiling H7 vaccine are under discussion within the federal government. In terms of the animal investigation, while humans have severe disease, testing indicates chickens and quail show no signs of illness. So we've talked about these concerns about some of the genetic features for increased binding to respiratory cells and replication and possible increased severity. Here we have an issue that the virus can infect animals but not cause any symptoms in them. And birds are also shedding virus well when they've been tested. H7N9 has been confirmed in chickens, ducks, pigeons, both feral and captive, and environmental specimens, and those are mostly associated with live bird markets. There have been greater than 4,000 swine that were tested in China, and all have been reported negative. So chickens, ducks, really poultry are where we're finding it. They're not having symptoms, and they are shedding virus. In the U.S., there has been ongoing surveillance for avian influenza, and they have not identified any H7N9 viruses in birds that have been tested. Looking at this at the map again, just to point out the open circles, those red open circles are where animals have been identified that are positive, and those are mostly in live bird markets. I think one important phenomena is down here where it says Guangdong and Sheng, that there have been identified animals, but there have not been identified any human cases, and that is very close to Hong Kong, which is right there. This just has some pictorials of what's happening in the live bird markets. Some information so far indicates that Shanghai may have a more liberal process for animals coming in and out of Shanghai and for how they manage their live bird markets, which is different from Hong Kong and different from Beijing. And so as a factor following the appearance of H7N9, there have been changes in terms of what they're doing in those live bird markets and the likelihood that many of them may not open again. To go back to the epidemic curve, what's listed here in the boxes are for each of those provinces or municipalities when they did institute live bird market closure, and whether or not this is a causal factor for the decline in cases, it certainly is associated in time with it. And so I think it indicates that there may be some mitigation that did occur through the closing of the live bird markets. However, there is also a seasonality to H5 viruses that we know about, and we expect that there may be seasonality as well to the H7 viruses, and therefore the decline in the epidemic curve may be, in fact, partly due to seasonal factors as well as mitigation factors, and that the appearance of the virus in the fall might occur. In conclusion, recognition and response has been faster and more transparent than in the past. Public health concerns do persist. There is a high severity of illness associated with this virus. There are genetic changes in the virus associated with mammalian adaptation and transmission. Birds may shed virus without symptoms, and that makes it a challenge for control efforts, and therefore really prompts us and others to have ongoing surveillance in animals. There are no new H7N9 cases that have had onset after May 21st, 2013. Whether this is the effect of live bird market closure, seasonal factors, or others is not clear. However, the cases may recur in the fall. There is no evidence of sustained human-to-human spread at this time. Ongoing surveillance in humans is needed, and vaccines are being developed and evaluated. And there are a number of people that provided a lot of information to this, especially the China CDC, which was a very good partner throughout this response.
Thank you. We do have time for questions for either Dr. Jernigan or Dr. Finelli. Dr. Curran.
Thank you for that update. I was just wondering if there is any information about serologic surveillance in China, either for contacts of cases or workers in bird markets or the general population.
Yeah, I did not have that for this talk. I don't know if Dr. Shaw, if you want to mention, if you know anything about the serologic studies.
The Chinese have done some preliminary studies. They're still getting their assays set up, but they are basically not finding serial conversion to any high level, which indicates that there aren't that many undetected cases so far. But as I said, they're still optimizing the serologic assays.
Dr. Vasquez?
Yeah, I was going to ask basically a same or related question. Going back to your slide on animal investigation, trying to figure out, you said that infection has been confirmed in chickens, ducks, pigeons, but that over 4,000 swine have been tested and are reported negative. And in another slide, you showed that there's only one asymptomatic infection. So I'm trying to figure out what proportion of the animals are positive, and if it's high, and showing those pictures of, you know, the pigeon markets and the workers, how come the rate of asymptomatic infection is very low? So I guess the first question is, what's the rate of positivity in the animals?
Yeah, I don't think we have a good denominator that we can use to say what that actual rate of positivity is. All the information we have is dependent on the Ministry of Agriculture from China. Okay. And so they are working through, I think, some of their assays as well. They have a means for collecting specimens and then testing them and then using culture as the gold standard for what they call a positive animal. And so that leads to probably less identification of cases. There is not an ongoing surveillance for asymptomatic animals. They have surveillance in place, but I don't think it's quite to the level that would be able to answer the question that you're asking.
And in your slide, you said that only one asymptomatic infection has been documented. Do you know how they assess that? Did they randomly tested 25 individuals, 1,000? Were they contacts of
that one
the
actually,
index cases?
I don't recall if that one was picked up through their ILI network or not. And
yeah, that was a contact. They've been testing contacts. You know, they were doing very intensive monitoring of contacts to look for fever and so forth, and also testing them. And so the asymptomatic person was a contact of one of the confirmed symptomatic cases.
Yeah, they are not routinely testing.
Yeah, they also did find a couple cases among they have very good influenza-like illness surveillance. It's been strengthened greatly in the past few years. And they just found, I think, a total of 6 confirmed cases through the ILI surveillance out of, you know, many, many thousands of specimens worked through. So it doesn't look like this strain was causing a big increase in ILI. It was really the very severe disease that was mainly in people with bird exposures.
Dr. Sawyer.
One of the potential advantages of the non-egg-based vaccines is rapid production as new strains arise, as in this case. I wonder, particularly with the recombinant vaccine, I wonder if you have any updated projections from those manufacturers about how quickly they could make a vaccine if you decided to ask for one.
Yeah, I don't have that information. I don't know if Dr. Gellin would like to respond to that.
I'll respond in part, and then maybe others can step in. I think the point is that, as has been highlighted, there's been a lot of attention paid to the machinery of vaccine development, of getting the viruses to move, turning them into seeds. Optimizing seeds is a key piece of this, of making sure that they yield as much hemagglutinin as possible, because that's going to have direct impacts into how much vaccine could be made. And then the commitment to develop product for clinical trials. So that's already going forward as far as to make sure that there can be vaccine that could potentially be available. There are a range of different technologies. So this is the front end, and a lot of the things that we learned in the past that have now tried to collapse the front end. I didn't highlight all of them, but there are a bunch of those. And then separately, if the manufacturers with different technologies are here, they may want to comment about how some of these different technologies are coming into play now. But there, as you suggest, there are now a range of these things besides eggs, the cells and recombinant, but varying capacities.
Dr. Shukat?
Yeah, just to expand a little bit, I think that we're in a different place than in 2009 because among the candidate vaccine development work beyond the inactivated egg-based and LAIV that we had in 2009, there are cell-based and recombinant vaccine development activities going on. And there has been, potency and sterility and manufacturing dialogue that's much better than in 2009. But one thing we learned very well in 2009, that predicting capacity and production is not a winning strategy. There also are reasons from the H7 influenza vaccine literature to believe that it may be more challenging to make an immunogenic H7 vaccine, that in the studies that have been done in the past, it was sort of more like the H5 situation where you need large doses or adjuvant to get a good response. So there's a very active cross HHS and cross manufacturing dialogue going on right now, but I think it's it would be inappropriate to anticipate what kind of production we could get from the different strategies.
We'll take Dr. Keitel, and then we probably should move on.
Yeah, I want to follow up on the serology question. Have they been able to obtain post-infection sera from some of these people to see whether these assays are able to detect a sero response?
We'll let Dr. Shaw.
They have, but we haven't seen results yet.
So, yes, but we don't have any of that data.
Okay, let's move along to the updated adjusted estimates with Dr. Thompson.
So before I get to the updates from this past season, the flu work group suggested that I bookend the talk today by talking about VE results from the past prior several seasons, and also, since what I'm going to show you today focuses on outpatient outcomes, talk a little bit about inpatient outcomes. And I'll also compare what we saw with the interim results with what you're going to see today. So as all of you know, the answer to how effective the vaccine is, the answer to that varies by age and other host factors and the vaccine and virus and season in question. The studies we do here in the U.S. are observational studies where we're comparing the odds of vaccination among cases to the odds of vaccination among controls. And the study design that we use for the U.S. Flu VE network focuses on what's called the test negative design, where our controls are people who are seeking care for respiratory illness but tested negative for influenza. So for the past two prior seasons, here are the results by the age groups that we organized them with at the time. And the dots there, those are the point estimates of vaccine effectiveness against circulating strains, and those lines are the 95% confidence intervals. So Mike Osterholm's group released a pooled estimate for adults for the time period of 2004 to 2008, 59%. And so when you compare that point estimate to the other adult estimates here in white, you see that what we've seen for the past couple of years, at least for the adult age groups, have been consistent. So for this season, as most of you know, the U.S. Flu VE network consists of 5 sites across the United States. Our focus is on outpatient visits. And the design, as I mentioned earlier, is the cases are PCR confirmed flu, and the controls are also ARI patients, but who tested negative for influenza. So the results you're going to see today are still interim in that we're still waiting for final medical records and are relying on self-report vaccination status for one of our sites. But what you're going to see today reflects, vaccination reflects fitting within the ACIP recommendations for days prior to illness onset, and for kids under 9, the combination of doses recommended. And the adjusted estimates control for same things we've done in prior seasons: age, sex, site, days since illness onset, and calendar time. And then for what we've seen in this season, some potential confounding by race, ethnicity, and self-rated health. So here's the epi curve for this season, and as Lynn was saying earlier, we have had an early season, very robust season. In blue are the cases. We had close to 2,000 cases and about 4,000 controls. And also similar to what Lynn was saying, in the end, over half were H3s. We had a significant B bump at the end, with most of those being Yamagata, but also Victoria lineage, an extremely small number of pandemic H1s. So here is the typical table that we always show the V results in. If you follow that white line for all ages, you'll see that 33% of the cases were vaccinated compared to 50% of the controls. And once you adjust for the patient and illness characteristics I mentioned, that gives us a VE of 52%. So in order to not blind yourself trying to read it, here are the numbers with the columns by age group. And again, the point estimates are the numbers, and those bars, the 95% confidence intervals. So this is against all circulating strains. And here, in even greater and blinding detail, is again, it's H3 and B, and we'll just jump immediately to the graph here. So on the right side is looking at VE against B only, so B of either lineage. And see, we got quite respectable VE numbers against B this season, and significant VE for all age groups, which we've never had sample sizes in the past that have been able to, for us to say definitively we had significant VE for all age groups against B, so that's nice. On the left side is the VE against H3, and of note, which has been discussed before, the disappointing VE among the 65 plus. And then also a little different is once we got to be able to divide the kids under age 18 into 2 age groups, we saw a VE of 50% looking at the full immunization of children under 9, but a lower than expected VE against H3 in the age 9 to 17 group. So we also were able to, thanks to CDC laboratory folks, to subtype, to look at the lineages of the Bs, and again, easier to see in a graph. But on the left is VE against the B Yamagata, which was the component in the vaccine, and on the right is the VE of that vaccine against the circulating Victoria lineages. And as you'll see, we have very similar overall VEs, both all ages and then age groups against both of these lineages. So in conclusion, we saw an overall for all ages adjusted VE of 52%. This is similar to what we brought up during the season, also similar to international estimates that have come out. And this translated into the potential to reduce the risk of outpatient visits by half due to H3, with the exception of the children aged 9 to 17 and those over age 65, where we need to do additional research to understand what was going on in those age groups. And then in B, for all ages, we appear to have reduced the risk by 2/3. And as I mentioned, saw similar VE against both lineages. This is the second year in a row we've seen that. And we still have work to do, including looking at chronic medical conditions and breaking down by vaccine type. So here then places this season on the far right alongside the 2 prior seasons. And as you'll see, it's a pretty consistent story, with each season the older adults having a somewhat lower VE. And as I mentioned, and as all of you know, we had a couple of different interim results. We had accrued unadjusted VE that was released in January, and then what turned out to be a mid-season adjusted VE in February. And the good news with that, we felt, was it allowed us to address some early misconceptions about the vaccine's performance. Specifically, we were hearing from state health departments that they were seeing, quote unquote, unprecedented numbers of vaccine failures. And so it was reassuring for us to see that the VE we were seeing was similar to past seasons, and that now in retrospect we realized was really due to the volume of circulation and the fact that it was predominated by H3. And in the process, especially among older adults, we're able to get messages out there about clinical management and the importance of antivirals as a second line of defense. And in general, our earlier and later estimates were consistent, with the exception that we are kind of limited by the numbers and the age strata we look at, which is what I'll show you here. But overall, against all circulating strains, all ages, these are the three estimates we've put out there. And so you see they go down kind of stepwise, and the confidence intervals get smaller, but not a substantially different story. Here on the right box is against B only, on the left box is against H3 only, and each of those three also show this stepwise decline. And to really get in the weeds, I regretted putting this in after I did it, but things that I find interesting, I realize not everybody finds equally interesting. But the boxes are age groups, and on the left within each box is the interim adjusted estimate for that age group, and on the right is the full season estimate. And so starting on the far right, you see that we went up from 9% to 19%, yay, against H3 for older adults. And but on the left side, once we broke out the two age groups, and kids saw lower and different estimates come out. And here similarly is down in the weeds looking just against B, with the point that in some age groups the estimates seem very stable, in others there seems to be a steady drop. And then finally, so everything I've showed today is, again, against outpatient outcomes. Obviously, a primary driver of our flu program is to prevent inpatient outcomes. So here are three studies looking at recent seasons, looking at hospitalized flu cases using a similar design where they're looking with the controls being testing negative for influenza. And each of these numbers, well, let me say the two bookends, the 2006-09 and the 11-12 are both from Kip Talbot and Marie Griffin at Vanderbilt. The one in the middle is from a hospital network in Spain. But each of those numbers is at or higher than the estimate we had for the same age mix looking at outpatients. So in here also, interesting to me, but perhaps not interesting to everybody, are recent results by this group in Spain, where they, instead of looking at this test negative design, used age match controls. And so on the left is still looking at just the general prevention of outcomes, similar to what we talked about before, but that far left number, the 57%, is looking at inpatient flu cases versus controls being other hospitalized people for non-respiratory illness. So somewhat reassuring that we get a similar number with a different type of control. And they saw actually higher VE when they looked at the ICU severe inpatient flu cases. And then on the right is looking at the ability of the vaccine perhaps to modify disease outcomes. So all of these are patients who are infected with flu. And so that little, sticking up that little small tip is the upper end of the 95% confidence interval comparing the inpatient flu cases with outpatient flu cases, so they didn't notice a difference there. But they did notice a difference looking at the ICU flu patients versus those that were getting care on the hospital ward to suggest that perhaps even among those who were infected with flu, that the vaccine may have reduced the likelihood of more severe illness. So our takeaway in general is that what we're seeing are numbers that are consistent with what we're observing in outpatient settings, and that the theme seems to be it's reducing risk by about half. But we currently don't have a U.S. platform to look at these items, so we are going to have to depend upon the kindness of academic strangers in other countries for the time being. And that there are still, I think, very important questions about mild versus severe illness that would be exciting and have a lot of potential implications. And finally, I want to point out that all the things I showed you is actually the result of a lot of other people's hard work. So, thanks.
Thank you. Why don't we move on with the safety discussion, and then we can take some questions on both safety and efficacy following this. Is that okay?
Good afternoon. Today I'll be giving an end-of-season update on the 2012-2013 influenza vaccine safety monitoring. So I'll update you on Vaccine Adverse Event Reporting System, or VAERS, influenza vaccine surveillance, to include a general VAERS influenza vaccine update, and also updates on high-dose trivalent inactivated influenza vaccine, intradermal TIV, pregnancy outcomes, anaphylaxis following influenza vaccination in suspected egg allergic patients, and vaccine safety data link influenza vaccine surveillance. So starting off with VAERS surveillance for the 2012-2013 season. Before I start, I want to say that the VAERS data for this particular review end on May 4th. But at this stage in the season, we don't anticipate too many more reports coming in. So this is just a background slide on VAERS, and I know you're familiar with VAERS and the strengths and limitations, so I won't spend much time on this slide. So U.S. reports to VAERS following trivalent inactivated influenza vaccines are summarized on this table. And on the far right-hand column, you see the 2012-2013 season in yellow, and then we have the previous season for comparison. And we're looking at total reports, and these are U.S. reports. The number of serious reports, the number of non-serious reports, the number of Guillain-Barré syndrome reports, and the number of anaphylaxis reports. You can see between 2012 and 2013, comparing to the previous seasons, these are pretty comparable numbers. And approximately 121.9 million TIV doses were distributed in 2012-2013. And there was no disproportional reporting and data mining for Guillain-Barré syndrome, febrile seizures, or anaphylaxis for 2012-2013. And FDA provides the data mining data for this analysis, and actually for all subsequent data where I'm going to report on data mining findings. This table is U.S. reports to VAERS following live attenuated influenza vaccine. And again, the current season on the right-hand side, and then the previous season for comparison to the left. Roughly the same number of total reports. There's a slightly higher number of serious reports, but when we looked at those reports, we did not find any unusual or concerning patterns. Roughly the same number of Guillain-Barré syndrome reports. And there were a few more anaphylaxis reports this season following LAIV compared to the previous season, but I want to note that these are very small numbers. And when we actually looked at these 5 reports, 4 of the 5 had multiple other vaccinations administered at the same visit, so it's hard to draw any conclusions about those reports. Approximately 13 million LAIV doses were expected for 2012-2013. That information was provided by the manufacturer before the start of the season. and no disproportional reporting and data mining for GBS or anaphylaxis was detected for 2012-2013. So this table summarizes flu zone high-dose reports in VAERS. And again, the 2012-2013 season on the far right-hand side in the yellow column. And then we have the previous 2 seasons for comparison. This represents all of the first 3 seasons of flu zone high-dose use in the United States. And again, looking at the total number of reports, the number and percent of serious reports, the percent female, and the median age range, these are pretty comparable across the first 3 seasons of use for flu zone high dose. And common signs and symptoms following TIV include pyrexia, chills, nausea, vomiting, headache, and injection site reactions. So looking just at the reports for this season for flu zone high dose, a disproportional reporting and data mining was identified for vomiting and drug administered to patient of inappropriate age. And the data mining, the vomiting data mining finding has persisted since 2010, 2011, the first season of use. So this does not represent a new safety concern. And most reports of vomiting are non-serious and self-limiting. And vomiting is frequently accompanied by the coded outcomes you see here. And what this means is, for example, for VAERS reports, VAERS high-dose reports where vomiting was a coded outcome, 51% of the time nausea was also a coded outcome in that report. And I don't know how much the nausea helps you, because presumably most people who vomit are nauseous. At least that's been my experience. But if you look at the other 3, that 41% of the time chills were also coded, 36% diarrhea, and 30% pyrexia. So moving on to flu zone intradermal reports in VAERS. Again, same format, the current season on the right and the previous season for comparison. And this represents the first 2 seasons of flu zone intradermal use in the United States. There are more reports, and this could possibly represent increased uptake and use in the marketplace. But if you look at the percent serious, the percent that were female, and the median age range, they're pretty comparable to 2011, 2010. And common signs and symptoms following TIV intradermal, those of mild and self-limited injection site reactions. So for flu zone intradermal reports for the 2012-2013 season, disproportional reporting and data mining was identified for injection site nodule, injection site pruritus, and drug administered to patient of inappropriate age. And local reactions are in a package label and are expected. So findings for injection site nodule and injection site pruritus do not represent new safety concerns. Moving on to a summary of VAERS reports for TIV administered during pregnancy for the 2012-2013 influenza season. There were 43 total TIV pregnancy reports, and of these, 14 were spontaneous abortion reports. That's about 1/3 of the total TIV pregnancy reports, and spontaneous abortion is the most common pregnancy-specific adverse event. There was 1 placenta previa, 1 excessive bleeding during labor, and 27 non-pregnancy specific reports or no adverse event reported on the VAERS report. No reports of major birth defects. So to put these numbers into context, approximately 2 million pregnant women received influenza vaccine during the 2012-2013 season. And when we reviewed these reports, we identified no unusual patterns. So moving on to influenza vaccine administration in patients with a history of egg allergy. Just to refresh here, the recommendation for egg allergic patients was updated for the 2011-2012 season. And just generally, those recommendations were that persons with a history of egg allergy who have experienced only hives should receive TIV with some additional safety measures. And persons with more severe reactions to egg should be referred to a physician with allergy expertise for further risk assessment. So CDC has conducted enhanced monitoring for allergy and anaphylaxis in VAERS since 2011-2012, the season that these new recommendations went into effect. And what we do is we search for the code anaphylaxis combined with a text search for egg. And then we manually review all the reports that come out of that search and the medical records to identify potential cases of anaphylaxis in individuals with possible allergy to egg. And then VAERS reports of possible anaphylaxis in suspected egg allergic patients are reviewed through CISA's Clinical Immunization Safety Assessment Project, commonly known as CISA. So here we have the CISA assessment of VAERS anaphylaxis reports after influenza vaccine in individuals with suspected egg allergy. The time period covered is July 1st, 2010 through May 3rd, 2013. So the CDC search identified 4 reports, and these 4 reports were based on the criteria that I just explained on the previous slide. And the CISA project reviewed the 4 cases, and they included 3 TIV reports and 1 LAIV report. 3 of these cases did not meet the criteria of, number 1, existing egg allergy, number 2, diagnosis of anaphylaxis, and number 3, anaphylaxis was consistent with a reaction to egg protein in the vaccine. So they had to meet all 3 of those. 1 case did meet the criteria. This person was vaccinated in 2012-2013. He's a 12-month-old male with a history of atopic dermatitis and egg allergy. Developed generalized urticaria, dyspnea, cough, wheezing, and angioedema of the uvula following TIV. The child had never ingested egg in the past. So this child, based on a personal history of allergy and a strong family history of allergy and food allergies, received testing and was prick test positive for ovalbumin, so had never ingested eggs, and had received the vaccine and subsequently had an anaphylactic reaction. The case met Brighton level 1 criteria. So the take-home message for this review is not really to get wrapped up in the details of this case or the 3 that were ruled out, but just to know that in our surveillance for VAERS, we did detect an individual who, after expert review, was determined had an existing egg allergy, had a diagnosis of anaphylaxis after receiving TIV, and the anaphylaxis was consistent with a reaction to egg protein in the vaccine. So moving on to vaccine safety data link surveillance for 2012-2013. This slide is in here for reference. Near real-time monitoring or rapid cycle analysis, the pre-specified outcomes for TIV and LAIV for this season were Guillain-Barré syndrome, seizures, encephalitis, myelitis, and encephalomyelitis, and anaphylaxis. And RCA used automated data from approximately 9.2 million health plan members at the VSD sites. So for this past season, there was just over 3.6 million TIV dose 1s. Of these, there were 31,000 high doses, dose 1s, and 4,700 intradermal dose 1s. And the TIV high dose and TIV intradermal were included in the total you see here, the 3.6 million, but they were dropped from the final analysis for RCA. And there are roughly 260,000 LAIV dose 1s. And the bottom line is no signals in rapid cycle analysis during the 2012-2013 influenza season for any pre-specified outcomes were detected. So in summary, no new safety concerns were detected for TIV or LAIV during the 2012-2013 season. A review of pregnancy reports in VAERS identified no unusual patterns. In a review of VAERS reports for the past 3 influenza seasons identified 1 case of anaphylaxis in an egg allergic individual following TIV that was consistent with reaction to egg protein in the vaccine. So next steps, we'll continue targeted enhanced VAERS surveillance for 2013-2014 to include a physician review of reports for pregnancy, anaphylaxis in egg allergic individuals, and for the new vaccines, the quadrivalent IIVs and quadrivalent LAIV, cell culture-based IIV, and recombinant IIV. And as far as vaccine safety data link near real-time monitoring for 2013-2014, surveillance of the new vaccines will depend on the number of doses observed in VSD. I'd like to acknowledge the following individuals for their contributions to this presentation. Thank you.
Thank you. Going to check real quick to see if Dr. Dushin is on the phone bridge. Jeff, are you there? I assume that means yes. We're open for any questions on the vaccine efficacy or safety. Yes, Dr. Herman.
So I have a question about efficacy. So the efficacy of the H3N2 vaccines varied widely amongst people under 65 in different age categories. And so will we see perhaps next year some look at VE by various formulation of vaccine? Maybe that might be an explanation, different uptake in different age groups and so on?
Yes, and I think one of our goals is to try to be able to incorporate vaccine type into the interim estimates as well. Thus far, we've only had enough LAIV to do estimates for the under age 9 group. We had a few dozen over age 9, but don't have much even across seasons to look at that. And then in terms of high dose or other formulations, I think maybe we had a dozen this season. So I don't know that this is going to be the platform that can do that, although certainly important question.
Dr. Harrison.
So this is a follow-up, actually. Given the disappointing data in the 65 plus age range and the importance of understanding if the efficacy or effectiveness is higher for the high-dose vaccine, if this isn't the right platform, how do we address this issue?
I'll defer to others who probably can speak better to that. I will say that one option, and probably not a very practical option, is to enrich the local. All of these sites have a pretty clearly defined source population, and they and their health plans are all open to enriching their membership with more high-dose vaccine, for example, but that may not be a practical option.
Dr. Sawyer or Dr. Keitel, why don't you?
Well, just in response to that, I know of at least one study underway comparing the high dose to the standard dose in the elderly.
Dr. Sawyer?
A question also on efficacy for Dr. Thompson. For us non-influenza experts, can you comment on how surprising the cross-protection for influenza B Victoria was? And I believe you said it happened last year as well. And what are the implications for the utility of the new quadrivalent vaccines, which I thought were designed to address a lack of cross-reactivity?
Well, I will say that if you go back even a couple of years prior, the V against B was not especially good. So it's hard to know how any one of these years kind of applied to policy. Another thing that we plan to look at is prior year vaccination, and there's some indication that some of this could be due to the fact that people get repeated vaccinations, and last year they would have gotten the Victoria lineage actually past several years.
Dr. Hahn?
Dr. Sawyer asked my question. Thank you.
Okay, Dr. Karen.
Actually, two questions, and one is related to the comment that you had just made. With regard to B efficacy, I was wondering, I think it's great that we're stratifying children. I'm wondering if we can stratify even more if we have the numbers to do that, because I think that it's really very possible. 6 months to 8 years of age is a really wide range, and many of those older children have gotten multiple vaccines, including B vaccines from the other lineages, whereas the very youngest infants may not have gotten seen B from both lineages. So it would be really interesting if we could further stratify that. So that's one question, and then the other is, given your comment, both Lynn's data about the high number of hospitalizations in the elderly this year, and your comment on relying on the kindness of strangers, do you know of any plans this year from academic institutions to look at efficacy against hospitalization in the elderly?
So for the first part, let me ask you, what do you think the good cut point under the age of 9 would be? Would you at 5? What would you do?
Well, honestly, if you had I'll look at my other pediatric colleagues, but if you had the numbers, I'd actually look at 6 to 24 months maybe, and then you think 3, Jan? Okay, Jan is voting for 3, 6 months to 3 years, and then 3 to 8 or something like that.
Okay. No, we can definitely do that and share it with the work group. Confidence intervals will be very wide, but it's sometimes interesting to see.
To see that.
And I'm not aware of others, but is anybody else aware of other plans to study the against hospitalization this coming season in the U.S.? Wendy?
I think it's worth remembering that one shouldn't stare too long and hard at a single variant in a single year, but rather a trend over many years, because it's well known that different vaccine antigens may be more or less immunogenic. So, for example, it would be very interesting to know how immunogenic the H3N2 component was for the 2012-13 season, and I simply have seen no data, and that would be nice to see in the elderly. Did they even respond well to vaccination, primary vaccination failure?
Dr. Brady.
I'm just wondering a little bit, and I'm sure it's very difficult to change because you have all the data, is comparing individuals who have positive results for influenza versus those with influenza-like illness who are negative. It seems like there may be a lot of confounding there, because my guess is some of the individuals who have influenza-like illness during influenza season and are negative actually have influenza. Whereas it might be more valuable to try to identify just a cohort of people that are matched for age and gender and potentially underlying illness that don't have any medical problems, to try to see whether or not there's a difference. Because I don't know where those people with influenza-like illness who are negative but have influenza would fall in the vaccinated or unvaccinated, but that may have implications for the comparison.
Yes, and I think I did mention it in the presentation. One advantage of what we do, though, is we do limit it to people who've only been sick less than 7 days. So given that we have a highly sensitive test, we can have some confidence that the negatives, at least for that illness, don't have influenza. But I do agree that there's a value in looking at other control types, and which is the reason I liked the Spanish study I mentioned. Also, in a pregnancy study we finished recently, we were able to use the test negative controls and then also matched community controls as you're describing, and came up with identical results, which that's reassuring.
I'd like to kind of pick up on what Dr. Brady said as well, and I personally have some fairly significant concerns about the methodology, just in that I think we assume PCR performs equally well across ages, and I don't think it does. I think the interplay between age, time from onset of illness to when you're sampling, and the whole clinic-seeking behavior across ages is so confounding that it makes the results almost uninterpretable. So I'm concerned about that, and I also toss out, for example, if you were to add in a layer of multiplex PCR and pull out kind of a non-entity, so testing people for human metapneumovirus and looking for influenza vaccine efficacy against something that it shouldn't, that gives you control whether or not the methodology is functional, or if we're just seeing all these other things come into play.
and I think Wendy wanted to make a comment, but I would say that this test negative design, which I was actually skeptical of when I first heard of it too, seems pretty effective at controlling for this health-seeking behavior. There's no doubt that these people in outpatient care have higher vaccination rates than people in the community. But I mean, they're definitely important questions. And there are some studies coming out where comparing to test negative not only to influenza, but against other respiratory pathogens or positive for some other respiratory pathogen, as you're pointing out. And I think those are good studies. The ones I've seen thus far show similar results. Wendy, you were going to say something?
Dr. Bennett.
I just have one question that's sort of analogous to some of the discussion we've been having about comparing specific vaccines to one another, and that is when looking at the VAERS data, it's kind of hard to track kind of what the implications are of the data without some kind of denominator. And I noticed in a couple of your slides you did have some estimate of the distribution of vaccines in the U.S., but I wondered if you've thought about any methodology for essentially determining rates of adverse events.
When we display the distribution data, if we were going to calculate a rate, we'd be calculating reporting rates, which aren't ideal. In order to get true reporting rates, we would have to use coverage data and calculate doses administered. However, we don't have any way, to my knowledge right now, of capturing that data by product. The way we actually do product-specific monitoring is through FDA's data mining, where they're actually looking at a specific product compared to the other products that are captured in the VAERS database.
We have a question at the microphone.
Yes, hi, thank you. David Greenberg, Sanofi Pasteur. I thought I'd address some of the questions and comments that were made about Fluzone high-dose vaccine. As you know, this vaccine was licensed by the FDA under an accelerated approval process based on its safety and superior immune responses compared to our regular Fluzone vaccine. So as part of that process, we conduct a post-licensure efficacy trial. So this is a double-blind randomized study among approximately 30,000 persons, all 65 years of age and over. And we anticipated providing results from that study in 2015, and that was substantiated by the fact that the study was started last season, which was one of the mildest seasons on record. So we didn't have a good start, but this season, of course, was a more severe season. So I'm pleased to report that a recent analysis of the cases that were collected both last season and this season shows that we've collected enough influenza cases to conclude the study. So in fact, the laboratory work and safety follow-up will be conducted the rest of this calendar year, and we plan to supply the data and the study report to the FDA in the first quarter of 2014.
Thank you very much. Other questions? I guess we move on to Dr. Gillen.
Just a comment. Rich and I were talking about this. I just want to remark on that the 2 million pregnant women were vaccinated this year. We can all do the math. We know the birth cohort, and we know the percentages. But to put that in hard terms of 2 million people have now protected, and years ago that wasn't the case, I think is really remarkable. And it gets back to our discussions before about, that now that is the maternal immunization platform. So I think we have to thank 2009 for that and all the work that this committee has done and the obstetricians who've now kicked in to do that. But I was struck by the 2 million number.
A good thing to note.
May I follow up by saying that's really 4 million people that were protected, right?
Laura, can you clarify that, please?
Okay, we'll move on to Dr. Jain. Nancy.
Good afternoon. So my name is Varsha Jain, and I lead the seasonal influenza development team at GlaxoSmithKline. And it's my pleasure to be here and present GSK's second inactivated quadrivalent influenza vaccine. I came in October, and I had presented the data for the Dresden manufactured quadrivalent influenza vaccine. So this is the development plan for FluLaval. I will present very briefly also the trivalent and in a little more detail quadrivalent vaccine. So FluLaval TIV is licensed in the US for adults as of 18 years of age. In 2012, we submitted 2 supplemental biologic licensing applications, one for TIV, to expand the age indication to 3 to 17 years because it's approved as of today only for 18 years of age and above. For QQIV or Quebec-based quadrivalent influenza vaccine, we submitted the initial indication for 3 years of age and older. The target indication for FluLaval quadrivalent would be active immunization for prevention of disease caused by 2 influenza A virus subtypes and the 2 influenza B virus types with 2 different lineages contained in the vaccine in adults and children from 3 years of age. So these are the studies that were part of the BLA licensing application. The first one in light blue or dark blue is the TIV study, where we demonstrated immunologic non-inferiority to a US licensed comparator in 3 to 17 years of age. We conducted the study in about 2,000 subjects. The control vaccine was Fluzone. I would not present the data from this study, but I will describe in detail now quadrivalent vaccine. So the QIV-003 was a pediatric immunogenicity study, and this was done in children 3 to 17 years of age, where we demonstrated immunologic non-inferiority and superiority of the added B strain in the quadrivalent vaccine versus a US licensed comparator. The comparator in this study were 2 trivalent vaccines. One was Fluarix with Victoria B lineage, and another Fluarix with Yamagata B lineage. This way we could compare QIV, which contained both lineages, to individual TIVs. Similarly, the adult study, the primary objective was to demonstrate lot consistency, but also the key objective was to demonstrate immunologic non-inferiority and superiority of the added B strain versus the US licensed comparator, and the comparator in this case was FluLaval trivalent vaccine. And lastly, I'll describe the efficacy study where we demonstrated efficacy in children 3 to 8 years of age, where we used quadrivalent vaccine as the test vaccine, and the control vaccine was hepatitis A vaccine called Havrix. Overall, in the quadrivalent studies, we had total exposure of more than 4,500 subjects, so we have safety data based on 4,500 subjects, and there were 3,500 children among those. So let me describe in brief results from the immunogenicity studies, both from pediatric and adult. So this slide shows you the hemagglutination inhibition antibody responses in terms of geometric mean titers. And on the left hand side, on the y-axis, you see GMTs, and then on the right side, you see responses against 4 strains contained in QIV, and also 3 strains contained in the TIV, and the second TIV contained the B Yamagata. So the circles here denote the non-inferiority analysis. So we demonstrated non-inferiority in terms of the common strain of QIV versus the TIV. So TIV and QIV, where the common strains were, we demonstrated non-inferiority, which is denoted by the circles. And we also denoted we showed superiority of the strain which was added to the QIV versus the TIV. So the TIV which did not contain. So here you can see that there was little cross-reactivity observed, but the superiority is denoted by the arrow. I'll show you the data in terms of seroconversion rate as well for superiority. The next slide, this slide is adult study where you see similar pattern of responses where we showed non-inferiority in terms of common strains, which is denoted by the ovals, and we also showed the superiority, which is denoted by the arrows, red arrows. So this is the slide which shows a fold increase or in terms of GMT ratio and increase in terms of seroconversion rate difference by adding a strain versus not having that strain in TIV. So we compared QIV to TIV, and these data show you the increase in terms of GMT ratio and seroconversion rate difference. Overall, more than twice, the GMT ratio were more than twice, and the seroconversion rate differences were more than 20%, but in children, you see that there were higher responses. So the fold increase for the GMT ratio was 2.6 to 3.8, and whereas the seroconversion rates were 33 to 44%. In terms of safety and reactogenicity, you can see that the quadrivalent vaccine showed slightly more pain. Children reported slightly more pain compared to TIV. And in pediatric study, children from 6 to 8 years of age were given 2 doses depending on their priming status. So if they were unprimed, they received 2 doses. After the second dose, this pain difference was not observed. Other safety endpoints in terms of any adverse events, medically attended adverse events, or serious adverse events were comparable between QIV and TIV vaccines. Similarly, in adults, we observed reports of slightly higher pain compared to trivalent vaccine in the QIV. But we did not observe any other differences in terms of adverse event reporting, medically attended adverse events, or SAEs. So I'm really pleased to now present the efficacy study data. This is the largest efficacy study done for a trivalent inactivated vaccine, which is submitted for a licensure application. So largest randomized control study for a TIV. This was a randomized control trial where quadrivalent vaccine, our Quebec-based quadrivalent vaccine was the test vaccine, and the non-influenza vaccine was hepatitis A vaccine. And we enrolled more than 5,000 subjects who were randomized 1-to-1 to receive QIV and Havrix vaccine. Havrix acted as a placebo. They were further age stratified between 3 to 4 and 5 to 8 years. We gave them 1 or 2 vaccine dose depending on ACIP's definition of primed, unprimed. So unprimed received 2 doses. We performed the surveillance after receiving the first dose by active and passive routes. So active surveillance was by phone calls every week or every other week. And the passive surveillance was that the parents were trained at the time of enrollment of study that they had to report any influenza-like illness. Once an influenza-like illness was reported, we obtained nasal and throat swabs, and for transportation, both swabs were combined. So the key confirmatory objectives that I want to talk about this study today and show you the results were any RT-PCR confirmed influenza, and also a more clinically consequential endpoint, which is moderate to severe RT-PCR confirmed influenza. So the definitions of any influenza, again, now this is RT-PCR confirmed influenza, is for any influenza, it was temperature greater than or equal to 37.8 degrees Celsius, and one or more of the symptoms on the same day, that is cough, sore throat, runny nose, or nasal congestion. What is moderate to severe influenza? It was a subset of any influenza. So this was with high fever, greater than 39 degrees centigrade, physician verified otitis, acute otitis media, or lower respiratory tract infections, or serious extrapulmonary complications of influenza. So moderate to severe influenza detects more clinically consequential outcomes of influenza. So to show you the results, we enrolled the study in 8 countries, and these countries were non-US countries, obviously, because the influenza vaccination is recommended in the US. We could not do a control study in the US. So in 3 regions of the world, as you see, in Central America, in Middle East, and in Asia, the first 4 countries listed here contributed more than 80% of the subjects in the study. The demography was similar between 2 groups, meaning QIV and the hepatitis group. Mean age was 5.4 years, and almost equal number of male and female subjects were enrolled. Majority of the children received 2 doses because they were vaccine unprimed. And obviously, we conducted the study where there was no influenza vaccine recommendation. So here you see the RT-PCR positive cases. There were 206 cases, and it was notable that they were almost one-third, and one-third in terms of H1, H3, and B Victoria. And that year, the study was conducted in 2010-11 season, so B Victoria was the strain that was recommended to be included in the trivalent vaccine. We only saw 2 cases of Yamagata, which was from Philippines. And you can see that the circulation of different viruses were varied among different countries. So it was not that you could predict that, countries which are nearby would have similar circulation. So here are the results. For any influenza, we demonstrated 55% efficacy. We met the primary endpoint. But interestingly, we observed higher efficacy against moderate to severe influenza or more clinically consequential influenza. We observed 73% efficacy. The lower limit of the 97.5 interval was 47. So what were these moderate to severe influenza cases? Well, majority of them were high fever, but you can see the relative risk. It was the efficacy in preventing high fevers as well as lower respiratory tract infections was similar, 70 to 80%. I won't comment on acute otitis media. There was only 1 case that was in control group. But of note is 3 pneumonia cases that occurred, and all 3 pneumonia cases were in control group. And here is influenza severity by subtype and by lineage. You can see that the vaccine, if there were breakthrough cases, for example, if you take a look at H1N1, in the QIV group, if the breakthrough cases occurred, they were mainly mild. So vaccine prevented moderate to severe influenza at a higher efficacy, or in other words, we can say vaccine attenuated the disease. Similarly, for H3N2 and B, you don't see the difference as well. This slide shows you the immune responses in terms of geometric mean titer. Pre and post GMTs are plotted here, and you can see that there was a robust response in terms of GMTs, more than 250 to more than 360. The GMTs were high enough for all four strains in the study, and no such increase was seen in the Habrix group or hepatitis A group. So in terms of safety, again, hepatitis A is a fairly inert vaccine, but we know that local reactions are common with trivalent and quadrivalent vaccines. Where you see the circles here is for local adverse events, and there were higher local adverse events, mainly due to pain. So this was about 47% versus 34% experienced local adverse events. In rest of the during entire study, we did not see any observe any differences in serious adverse events or in medically attended adverse events or grade 3 events for that matter. So to summarize, FluLaval trivalent has non-inferior immunogenicity versus US licensed comparator in 3 to 17-year-old. I did not present the data for this study, but the study is already published in PIDJ. And FluLaval Quadrivalent, the QIV, we met all objectives in all studies, in pediatric and adult studies. Efficacy, 55% efficacy was demonstrated against any influenza, and 73% efficacy against moderate to severe influenza. We saw superior immune response to the added B lineage versus the TIV. And we also showed non-inferiority, that is, additional B strain did not interfere with the responses of the TIV strains or the common strains. We observed acceptable safety and reactogenicity profile relative to the TIV or hepatitis A vaccine from more than 4,500 individuals who received QIV vaccine. So let me end with telling you what is the anticipated availability of FluLaval, TIV, and QIV. We expect that QIV and TIV will be licensed for 3 years of age and older by mid-August of 2013, so this year. QIV or quadrivalent FluLaval and the FluLaval TIV will have same presentation. So they'll be available in multi-dose vials with the preservative as well as pre-filled syringes without the preservative. So the TIV will be available for 3 years of age and older in 2013-14 season, pending FDA approval, and so will FluLaval Quadrivalent, pending FDA approval. GSK will make approximately 2 million doses of FluLaval. Thank you, and I can take any questions.
Thank you, Dr. Keitel.
Thank you very much for the nice presentation. I have 2 questions. The first is, your study design indicated that you age stratified the children, and I wondered if you had done subgroup analyses for the different age strata with regard to both the immunogenicity and the efficacy. And the second question relates to the pattern of the spread of influenza in the various regions where you conducted the study. I guess it was a continuous 180-day period. What was the seasonal occurrence of flu in the various different countries where you were?
So I'll take your second question first. The season in countries where we did the study was throughout, but there were peaks, and in some countries there could be 2 peaks. So we got in most of the countries we got the first peak, which coincides with the southern hemisphere kind of circulation. So, for example, we were looking at the distribution from the previous year to sort of estimate when will it start. And for Dominican Republic, in 2009-10, the season was started in May, but for us it started in April. So you cannot say exactly when the season will start. So the second question is about age stratification, and we did do analysis in terms of moderate to severe influenza and also for any influenza. And we do see that in 3 to 4 years of age, the efficacy against any influenza in 3 to 4 years is slightly lower, but efficacy against moderate to severe influenza is preserved. And I may have a backup slide for that. If Let me see. Yes, I think it's the first slide on the left. Okay, I wonder if, yeah, age-stratified vaccine efficacy. Yes. So as you can see, this is exploratory analysis. Study is not powered to show definitive results, but you can see the lower limit is above 0, and so any influenza it's 40% versus 5 to 8, 66%. But you can see against moderate to severe influenza, the vaccine efficacy is quite preserved.
Dr. Pickering.
Yeah, right now your there you are. Yeah, your flu larval vaccines 18 and older, but you're lowering the age for both pediatric and adults to 3. Is that submission linked, or is it possible that one will be licensed before the other, or will they come together? And then secondly, so your trivalent and quadrivalent, what will be the proportions available for next season?
Okay, so the submissions went probably a day or two apart. So the date is mid-August for both trivalent and quadrivalent from 3 years of age. To answer your second question, you said in terms of QIV, I think we presented for the Dresden-based quadrivalent, that is Fluorix quadrivalent, which is licensed. We will make about 8 or 9 million doses. But for FluLaval Quadrivalent, we will, since it's not licensed yet, so pending licensure, we will make about 2 million doses.
Thank you. Dr. Friedland?
Just to add, GlaxoSmithKline plans to distribute approximately 22 to 24 million doses of influenza vaccine across our portfolio in the coming season. Somewhere between 8 million, upwards of 10 million will be quadrivalent. Most of it will be the Dresden-based quadrivalent, which is currently approved. This new vaccine, should it be approved in August, we can have upwards of 2 million doses of quadrivalent available for in-season ordering.
Thank you. Other questions? Okay, I think Dr. Grohskopf.
Okay. All right, I'm going to present a summary of the new items proposed for inclusion in the recommendations for influenza vaccination for the 2013-14 season. Before I begin, I just want to acknowledge the very important and very much appreciated contributions of a large number of people who contributed to the conversations that the work group has had the last several months. And in particular, we did have a number of different discussions related to different aspects of ag allergy, but a wide range of topics as always, and we appreciate everyone's input. In brief, the draft, as such as it was at the time, 2013-14 influenza statement was circulated to the ACIP prior to the February meeting, and a number of concepts in there, the core recommendations for vaccination of all persons 6 months and older, the recently approved vaccines, at least that had been licensed up to that point, and the new abbreviations were discussed at that meeting, so I'm not going to spend a significant amount of time in this talk on those. New material that has been added since February 2013 includes the influenza vaccine virus strains that were selected for the 2013-14 season. These had not yet been confirmed as of our last meeting. The licensure of an additional new quadrivalent vaccine, FluLaval Quadrivalent, which we'll talk a little bit about, and 2 proposed minor modifications to the recommendations of vaccination for persons with a history of ag allergy. First, for information, a brief outline of the influenza vaccine virus is selected for the coming season. Trivalent vaccines will contain an A. California 7 2009 H1N1 virus, which is the same virus that's been for H1N1 contained in the last several seasons and is similar to the 2009 pandemic strain. an AH3N2 virus antigenically like the cell-propagated prototype virus A Victoria 361 2011. An A Victoria 361 2011 like virus was also recommended in the 2012-13 season vaccine. For this season, the specific candidate virus suggested is an A Texas 50 2012, which is an A Victoria 361 2011 like virus. And for B, a B Massachusetts 2 2012 like virus, which is a Yamagata lineage virus. For quadrivalent vaccines, in addition to the above 3 viruses, these will also contain a B Brisbane 60 2008 like virus, which is a Victoria lineage. The B viruses have come from 2 different lineages. They're divided into 2 different lineages, and as intended, quadrivalent vaccines will contain a representative virus from each lineage. Next, a brief summary of recently approved influenza vaccines anticipated to be available next season. At the last meeting, we discussed those that had been licensed to date, and those included quadrivalent live attenuated vaccine, Flumis quadrivalent from MedImmune, quadrivalent inactivated influenza vaccine, Fluarix quadrivalent from GSK, trivalent cell culture-based inactivated influenza vaccine, FluSilvax, which is from Novartis, and the trivalent recombinant hemagglutinin vaccine, FluBlock from Protein Sciences. These have all been added to the table of available vaccines, which is available on the CDC web pages, and an MMWR policy note was published with a link, URL link to that table in May. In addition, we now also have licensed just at the beginning of this month, quadrivalent inactivated influenza vaccine from Sanofi Pasteur, which is Fluzone. And the Sanofi Pasteur has previously given the influenza work group as well as the ACIP very recently a presentation of data on this vaccine. So I'm not going to go into a detailed presentation here, but just a brief summary and an acknowledgement that this vaccine that the ACIP has previously heard about has now been licensed. Again, this is Fluzone quadrivalent. This is from Sanofi Pasteur. It was licensed in June 2013, I believe on the 7th, so earlier this month. It's indicated for persons 6 months of age and older, so this is to date the first quadrivalent influenza vaccine that has an age indication below the age of 2 years. For the 2013-14 season, it's anticipated it will be available in 0.25 ml and 0.5 ml prefilled syringes, as well as 0.5 ml single-use vials or single-dose vials. And this vaccine will be included in the table of available vaccines in the 2013-14 influenza statement as an acceptable alternative to other licensed products when used within indications and recommendations. The last 2 slides go over the 2 minor modifications to the vaccination for persons with egg allergy recommendations, and I will address each one in a separate slide. I'll try to go over this one a little bit more slowly, only because it's somewhat busier than some of the other ones. This slide depicts the algorithm for egg allergy and determining when and whether referrals are needed to vaccinate. And this algorithm was originally developed for the 2011-12 season. This particular modification is proposed because we now do have an egg-free vaccine, which is FluBlock, the recombinant hemagglutinin vaccine, and this figures into this algorithm here. As you know, we also have now from Novartis, there has been licensed FluSilvax, which we discussed at the last meeting, which is a cell culture-based vaccine and is produced by a means that it's a cell culture and it does not involve propagation of the virus in eggs during the manufacturing process. However, because the reference candidate strains that are used to start the manufacturing process are passaged in eggs prior to manufacture, that particular vaccine cannot be considered egg-free, although it is expected it has a much lower quantity of egg protein than the other inactivated and actually all of the other current flu vaccines. For this particular slide, this describes the text in blue represents the current recommendations in the algorithm. The additional text that is proposed for inclusion is in red. The current recommendations as they stand take a stratified approach to influenza vaccination of persons with egg allergy, in that the first thing that's considered is what the symptoms the person experienced, their history of symptoms on exposure to egg were. In the left-hand side, left-hand column of boxes, second box down, for individuals who after eating eggs or egg-containing foods who experience only hives, that's their only symptom history upon exposure to egg, current recommendation is that those individuals would be recommended to receive inactivated influenza vaccine with some additional precautions, including observation for at least 30 minutes for a potential reaction following administration. It's proposed that administration of the recombinant influenza vaccine be added as an option for these persons if they are within the licensed age indications for the flu block vaccine, which currently it is licensed for individuals aged 18 through 49 years. Moving back to the left-hand side of the column, for persons who have experienced in their past any symptom other than hives on exposure to egg or egg-containing products, and this could include, of course, anaphylaxis, however, would include any other type of symptom, including but not necessarily limited to cardiovascular changes, respiratory distress, gastrointestinal symptoms, reactions requiring epinephrine or reactions requiring emergency medical intervention. The current recommendation is that these individuals be referred to a physician with expertise in the management of allergic conditions for further evaluation prior to vaccination. It is proposed that the administration of the recombinant influenza vaccine be included as an option for these persons if, again, they are within the licensed age indications for the vaccine, which is, again, 18 through 49 years. The second modification proposed for the egg allergy recommendations is intended to address situations similar to that described by Dr. Shimabukuro in his safety presentation earlier. That is specifically individuals who have no known history of exposure to egg and therefore no known symptomatology after exposure to egg, but who for one reason or another have had allergy testing performed and have results that are suggestive possibly of being consistent with egg allergy. It should be said that these testing results alone are generally not considered to be diagnostic without a clinical history. In general, the diagnosis of egg allergy is confirmed by a consistent clinical history of adverse reactions upon exposure to egg and egg-containing products, in addition to testing such as skin prick and serum IgE to egg proteins. However, those tests can be difficult to interpret in isolation when one is faced with them in isolation. There aren't absolute cutoffs for what constitutes a normal versus abnormal result. So with that in mind, also the further workup of such people would typically involve tests which would normally be performed by an allergist, such as, for example, food challenge testing. With these things in mind, it's proposed that the following be added to the egg allergy language. For individuals who have no known history of exposure to egg, but who are suspected of being egg allergic on the basis of previously performed allergy testing, consultation with a physician with expertise in the management of allergic conditions should be obtained prior to vaccination. So in summary, new items for discussion or vote, addition of FluZone Quadrivalent to the table of available vaccines. Because we're not, it's not, a preferential recommendation is not being proposed, this may not necessarily require a vote. We haven't generally been proposing inclusion within indications, for use within indications for vote, but it is there for discussion. Modification of the egg allergy algorithm to include RIV as referenced on the previous slide, which I can go back to as you need. And addition of language to address persons with no history of egg exposure but questionable allergy testing.
Thank you. We had previously discussed this, and being that each one of these represent a fairly minor change, we thought we could bring it together as a single vote as opposed to three separate votes. I'm open to discussion on that, but that was seen as a reasonable thing since there's no large or highly significant change going on here. That being said, any questions, comments? Dr. Sawyer.
You referred to your extensive discussion on egg allergy, and that discussion has left me with a bit of a communication challenge, and that is the inclusion of FluCellVax with all other egg-based vaccines as if they're all equivalent. Can you just share with us what the allergy experts told you about a femtogram of egg albumin. I assume I have that much on my iPhone right now, but whether that's really likely to cause allergic reaction. And the practical implication of my question is, why not say if RIV is not available, that the next best thing might be the cell culture-based vaccine?
A good question, and one that was subject of a fair amount of discussion. I will have to ask somebody from Novartis, if present, to comment on potential levels of albumin and other egg proteins in the vaccine. But there is no known safe threshold, absolute safe threshold for egg protein in the vaccines, and for regulatory reasons, the vaccine, FluLaval, we've been informed, can't be considered to be an egg-free vaccine. This makes it a little bit difficult to cite with some degree of concreteness how safe it would be. Many allergists would argue that because the current, and this was discussed also back in 2011, 2012, when we initially revised the egg allergy recommendations, that for the most part, the currently available inactivated vaccines that are produced by egg-based means are similarly not likely to cause a reaction. The difficult thing there, again, is that we don't really have an absolute threshold, and you can't necessarily predict. We do know that anaphylaxis can happen. It is probably not likely, but that it can happen. And given no threshold and also a low, albeit higher, and I'll leave it for somebody from Novartis to comment on how much higher versus lower content in other vaccines. It is, and the fact that it can't be considered egg-free, it makes it a little bit difficult to make a concrete recommendation.
Follow up, as I recall our previous discussion, clinicians were at least guided to use vaccines with the lowest available content in the previous recommendation. So wouldn't that be consistent to say that or to highlight that the new cell culture vaccine has by far the lowest content compared to any other egg-containing vaccine?
Yes, definitely. The current wording in the draft statement does discuss this, so that clinicians have that information and are able to utilize it.
Dr. Bennett.
Similar question. In the modification number 2, is there a reason why RIV couldn't be considered in this scenario?
That's a good point.
RIV is included as an alternative in the appropriate age group in the algorithm.
It is, but this new statement doesn't include it. It says refer. It's just in this, in the situation of giving vaccines, referral to a physician with expertise in the management of allergic conditions can be cumbersome and difficult, and if RIV could be given.
So we could propose to add, or if age appropriate, RIV.
Dr. Pickering.
Yeah, Lisa, one minor thing. All these abbreviations are a bit complicated, but at least IV 3 and 4 tell there's 3 and 4 antigens, but in your algorithm you use RIV rather than IRV3.
That can be further specified if desired. At present, that's all we have, at least as far as the recombinant vaccine. As far as we know, for the 13-14 season, it will only be trivalent.
Right, but unless people would read another table or the text, they wouldn't know or may not know this is a trivalent rather than quadrivalent.
That can be added. So that is a request to specify administer RIV3. Got it.
Other comment? Dr. Freihofer.
Lisa, are there any more updates as to the availability of the jet injector?
I personally do not currently have an update on that. There will be some discussion of that in the coming months within the work group. Wendy? Sorry.
Was there somebody in the back of the room with a comment? Other discussion?
Would you like me to go?
I think that would be helpful.
Okay, Clem Lewin from Novartis Vaccine. So the manufacturing process, as Dr. Grohskopf said, does not contain any egg because it's cell culture. Where the egg starts is in the seed that is used to start producing the vaccine. So there is a large series of dilution steps, and there is no egg protein detectable in the product. The 50 femtogram calculation comes from assuming the minimum dilution, not the maximum, and then also assuming that the protein stays there. And there's some evidence that might not be the case because trypsin in the vaccine, it's shown the clearance factor for trypsin is actually very high. So what we suspect could say is that the residual protein is no higher than 50 femtograms of egg protein, of which ovalbumin would only be a portion of it. So essentially that's probably the maximum theoretical amount that we have there. It's a bit like Dr. Sawyer said, it's very difficult to calculate because there isn't very much there. Does that help? Or
equal one whole molecule?
That I don't know. I will go back and work that out per vaccine.
Other discussion? We have had a suggestion to make a modification here, just to indicate RIV3 on this flow chart, and I believe that would, that would go on the flow chart. Any other suggested modifications? Dr.
To
Keitel.
add RIV3 to the proposed modification to the text. Modification number 2.
Can't go on the flow chart because the flow chart refers to ingestion of egg products.
Okay. Other discussion? Do we have a motion?
I make a motion that we accept the recommendations put forward with the modification just expressed to modification number 1 and the text addition to modification number 2.
Thank you. Can you second? Dr. Bikini? Further discussion? Seeing none, why don't we start with Dr. Harriman and go clockwise.
Harriman, yes.
Bocchini, yes. Nope, my backwards. I died.
Dr. Rubin.
Rubin, yes.
Coin Beasley, yes.
Vasquez, yes.
Sawyer, yes.
Campus Alcohol, yes.
Bennett, yes.
Tempty, yes. Dr. Dushin, are you on the line?
I am. I vote yes.
Dr. Dushin, are you muted?
I am on the line, and I'm muted. I vote yes.
We believe that was yes.
Yes, it was yes.
Okay, thank you. Dr. Keitel.
Keitel, yes.
Karen, yes.
Harrison, yes.
I think this is the second time I proved I don't know what clockwise is. Bocchini, yes.
Joe, you still have a couple years. The motion passes unanimously. Is there any public comment?
My comment. You have a microphone that works? Hello? Okay, thank you. Good afternoon. I'm Dr. Michael Royals, PharmaJet's Chief Science Officer. We design and manufacture jet injectors for needle-free delivery of vaccines into the intramuscular, subcutaneous, and intradermal tissue ducts. I want to share with you an update on the use of jet injectors for influenza vaccine administration. As many of you are aware, in 2011, the FDA asked industry for clinical data on the use of this technology for delivering flu vaccine. PharmaJet undertook the largest IIV3 influenza clinical study ever conducted on jet injectors to accumulate data comparing immunogenicity and safety when using jet injectors versus traditional needle and syringe. As many of you, an IND-approved study comparing jet injectors versus needle for flu vaccination was completed earlier this year, and the clinical study report was provided to the FDA last month. Results were made public at last month's National Influenza Vaccine Summit and will soon be made available on theclinicaltrials.gov and can be summarized as follows. The 6 co-primary endpoints of the study were comparison of the GMT ratios and seroconversion rates for each of the 3 strains of the virus. Also tracked were local reactions, solicited and systemic adverse events, and serious AEs. 1,250 subjects were enrolled. 2/3 of them were between 18 and 49 years old, and 1/3 50 plus. Blood draws were taken prior to vaccination and again on day 28. The GMT ratios and seroconversion rates showed no difference between needle and syringe and jet injection. The non-inferior study criteria were met for each strain. Local reactions were slightly higher in the jet injector group, but mild in intensity, well tolerated, and in line with historical published data on jet injectors over the past many decades. There were 3 SAEs in the study, and all were determined to be unrelated to the study. The data also showed non-inferiority when analyzing subgroups based on sex, gender, and body mass. The gap between the CDC's recommendation that every U.S. citizen over 6 months old receive a yearly flu shot and the typical influenza coverage rates of 45 to 50% is a challenging one to close. Reasons for noncompliance are multifaceted and complex. Estimates from published peer-reviewed literature place the proportion of the population that refuse vaccination due to needle fear and anxiety between 8 and 27%. Jet injectors have the potential to expand immunization coverage by pulling in those that forego immunizations due to fear of needles and dislike of needle injections. A compendium of published research regarding the impact of needle fear on immunization coverage is available in the hallway upon exiting. And if you would like more information on these devices, the recently completed clinical study, or domestic and international public health initiatives in which we participate around the world, please reach out to us via our website. Thank you.
Thank you. And if you can provide the website.
We'll get it in the minutes if you give the website.
Certainly, that would be our company. It's pharmajet.com. Okay, thank you.
Thank you. Any further discussion? Hearing an enthusiastic no, I think we can stand adjourned. Thank you very much, and travel well.